So I'm Erin Regan. I'm an LMSW and a PMHC, a perinatal mental health certified clinician. I have been in the field for the last 15 years in community mental health, and I actually am making the switch over to private practice full time too, like some of you guys mentioned you're doing as well. Um, I I got into like my focus is perinatal mental health, along with young adults, but I have a really deep passion for perinatal mental health just because of my own journey, and my experience with my daughter being born 3 weeks into the pandemic shutdown. That was like its own crazy experience. And then I had a miscarriage in between as well. So that's something that I also experienced, like that grief portion of that. And then my second child had some medical issues. So like kind of going through some of that has kind of spun me into this world of perinatal mental health. And like I think this field is extremely important. I think we have a lot of work to do, although we've made progress. People are hearing more about perinatal mental health and the things to look out for and whatnot. I do think we have a lot of work to do, even outside of mental health, right? Like, how do we support women within the medical environment, and how do we support them? How does the system, right? How are we there for families? So, um, yeah, that's me. So I'll kind of get into it. I'm no expert, just disclaimer, I'm no expert in this field. I'm still learning just like everyone. But I will try to cover as much as I can. There's a lot, as I was putting this together, there's just so much that I wish I could share. Um, I wish I could focus more within this on like abortion and things like that, but there's not a lot of time for that. So I'll try to get through as much as I can, but know that that is also a part of perinatal mental health and helping women and birthing people through all of this. Um, yeah, so what is perinatal mental health? It is pregnancy, conception through the first year of postpartum, is when we talk about perinatal mental health, that's what we're referring to. It affects both birthing people and partners. So a lot of people don't realize that partners can also experience the perinatal mental health disorders. It's not just depression. So a lot of people will, when you hear postpartum depression, you think of, or when you hear PMADs, right? Perinatal mental health disorders, you often think of depression. But it also includes anxiety, OCD, PTSD, and psychosis as well, which I will cover a little bit more as we go on. It's the number one complication of childbearing. I remember when I learned this in my training, it like shocked me that, this isn't something that's focused on so strongly, even in like, um, when we're seeing an OB-GYN or a midwife or whoever we're seeing for our care. This is not often something that's discussed from the beginning. Sometimes not at all. It depends on the provider, right? But this is something that I feel like, needs more focus. Some of the key statistics, so it affects 1 in 5 birthing people. 1 in 10 partners are also impacted by this. Up to 70% of birthing people hide symptoms. This can be due to like shame or fear of judgment or, worry that a provider might take certain actions if they share certain things. A lot of this has to do with like intrusive thoughts too, which I also will kind of cover in this. And then most go untreated or misdiagnosed. Here are some of the common mental health conditions that we talk about often in the perinatal period. And again, I'll break these down a little bit more throughout the presentation. But you've got, postpartum depression, postpartum anxiety, which is actually much more common. Um, this one seems to be very, very, very common. A lot of people can relate to the postpartum anxiety piece. Postpartum OCD, which can sometimes tie in with the anxiety piece as well. postpartum PTSD. You'll often see this, with birth trauma and things like that. And postpartum psychosis, which is a medical emergency. Again, I'll review this more, but that is an emergency. Some risk factors, right? This is not all the risk factors, but these are some of the main ones. Having a traumatic birth experience. I mean, it could even be not even just a traumatic birth, right? It could be a traumatic pregnancy, or, experiences that you have throughout the pregnancy. Maybe it's I've seen a lot of women that have gone through, right, a miscarriage and then get pregnant. And there's that trauma piece with the miscarriage that creates this anxiety or fear around what they're going through now that they're pregnant again. Lack of support. This is a really big one too. Support is huge to mental health, and it's such a large jolting sometimes shift in life, that the support piece is crucial, absolutely crucial to yeah, feeling like you can regulate and, feeling heard, feeling supported, feeling loved, all of that. Hormonal sensitivity. So obviously throughout pregnancy and birth, there's a lot of up and downs. Again, all the way through the first year. Women that choose to nurse, they'll go through this at different stages as well, depending on like how quickly they wean, or, if they're gonna do extended nursing, things like that. So there's a lot that involved with that as well. Um, and it's not just nursing, right? It's like a shift that our whole body goes through after birth. Sleep deprivation. So I know we kind of mentioned that before. That's a huge one. That can be a really, really tough one for families. Um, and we can kind of get into that a little bit more later too. Past mental health history. So this is also huge. Like if you have clients that are struggling currently with like symptoms of depression or anxiety, um, even like bipolar disorder, if they have a history of any mental health disorder, then we want to be very cautious of like being mindful that it may peak while they're pregnant or afterwards. Um, it definitely raises the risk of somebody experiencing a PMAD if they have a history of mental health conditions. Some symptoms and red flags to look out for. So like sadness, guilt, hopelessness, racing thoughts, right? Fear of harm to themselves, fear of harm to the baby. And that kind of ties in with the intrusive thoughts that we'll kind of get into more. Compulsions that come with those intrusive thoughts often, hypervigilance and nightmares, um, hallucinations or delusions, the psychosis piece. So these are things to kind of look out for. So I'm going to get into kind of like discussing some of these, the PMADs, breaking them down a little bit more. So with postpartum depression, right, you're going to see like a persistent sadness, tearfulness, maybe they're guilty or feeling guilty. There's a lot of like that mom guilt that everyone talks about, right? Of like, well, I want to, let my husband feed the baby in the middle of the night, but when the baby's crying, like I just can't overcome this guilt that I have to be the one to take care of them. Or, um, I really need time for myself. I need to get out and go get a pedicure, but like I feel really bad for leaving the baby, right? Like there's this piece, this mom guilt that we talk about often. Um, Fatigue and irritability is a big one too. This is another like word that gets thrown around a lot, the mom rage that people talk about. It's a very real thing, and it often happens within, like that first year, where there's and even after mothers experience this, right? Like even after, but there's often this intense anger that women are like, what do I do with this? Where is this coming from? This is not who I am, right? But it's very hard to control. Difficulty bonding with baby, appetite and sleep changes. And this is different from the baby blues. So you'll often hear people say like, oh, she has the baby blues. But depression is actually longer lasting and more severe. And so to kind of tell the difference between the two, I broke them down here. So with the baby blues, it usually comes up 2 to 3 days after birth. And it lasts only up to 2 weeks. If there are symptoms beyond the 2 weeks, it's most likely postpartum depression or something else going on. So that's something to be extremely mindful of. This is something that I say, like, if you take anything from this presentation, this is one of them, along with the intrusive thoughts piece, is that just paying mind to, like, if it goes beyond 2 weeks, we need to be looking at, like, um, supporting them in deeper ways and making sure that they have what they need. Um, there are mood swings in both of them, right? In depression, it might be more intense, more persistent. Um, Postpartum depression, also, I forgot to mention this, the onset can be any time in the first year. So sometimes it doesn't show up in the first 6 months, right? It might show up later. So this is something to also keep in mind, that if you have clients that recently had a baby, that you're keeping an eye out for those things. Impact on functioning. So, with the baby blues, it's more mild, more temporary, whereas depression is more significant and persistent. Um, Usually with the baby blues, it resolves on its own. And then with postpartum depression, we're going to look at, supporting them in deeper ways, like using therapy. Maybe some of them need medication. Um, like, every situation is different, right? But there are times where it is encouraged that if a client is on medications for or for depression or anxiety, that they, with the, consult a provider, a medical provider, but that they stay on those medications as long as they are okay for them to be on them with pregnancy, right? And I'm not a medical provider, but right, referring them out, making sure they have that support and that guidance on their medications, because they're more likely to have more intense symptoms if they get off of their medications, just depending, right? So making sure that we're referring out for those things. Um, Suicidal thoughts can be very rare with the baby blues. You don't often see that, whereas with postpartum depression, sometimes that can be present. Postpartum anxiety, like I said, is very, very common. You're going to see parents experiencing this excessive worry or fear around really everything, a lot of different things, right? It can be the baby's health or the baby's safety, their own safety, um, even small things, right? I say small, but right, it's big. It's usually big in the experience, but like, well, what is this rash on my baby? Like, do they have, the measles, right? Like, things like that can be very, very disturbing to them. There's some restlessness, racing thoughts, the typical things that you see with anxiety, right? Heart palpitations, sometimes there's nausea, and it often will co-occur with depression. Postpartum OCD. So this is where and again, the intrusive thoughts kind of play in with the anxiety piece too. You'll see these intrusive, unwanted thoughts. Sometimes it's even thoughts of, like, oh my gosh, I'm gonna accidentally harm the baby, or they have this, vision of something happening. It's very, very specific. Um, Compulsions, like checking, avoiding, reassurance seeking, right? Making sure, like, the baby's breathing in the middle of the night, waking up just to make sure they're breathing. That's a common one that you often will see. Um, the thoughts can be very distressing and not always aligned with values. And it's very important to distinguish that postpartum OCD is not psychosis. So they have insight into these intrusive, unwanted thoughts that they're having, and there's no intent to harm. Whereas with psychosis, that intent is there. So this is another really important thing to know, is that oftentimes people that are unaware of this is they'll hear, a parent might share this thought and it sounds very disturbing to a therapist, right? Like, do I need to call DCS? But that's where we have to assess if there's intent there. Um, so addressing intrusive thoughts, normalizing the experience is very, very important. And I have some little things in here to kind of guide you guys on what to say. Avoid alarming or stigmatized language, making sure that we're not making them feel bad or our reactions, right? Our body reactions, our facial expressions are not, we don't jump at what they say, that we're actively listening and supporting them in that space, giving them that safe environment to like open up and share because these things are not easy to share for many women and parents. Um, so again, distinguishing the intrusive thought from intent, and then assuring them that they're not alone or crazy. Because right when they have these thoughts, they might feel crazy, right? Like I'm out of control. What is happening to me, you know? So the gentle normalizing intro, you can say something like, many new parents have thoughts or images pop into their minds that are upsetting or even scary. This is actually a common part of postpartum mental health. Would it be okay if I asked about that? So if you have a client that recently had a baby, I encourage asking about this, bringing up, like, have you had any of these images or thoughts come to mind? I don't think I think it's been rare for me to not have somebody bring up at least something that's popped into their mind. So this is very common. Exploring the intrusive thoughts. So you can say something like, have you noticed any thoughts that feel out of character or disturbing for you? Like something bad happening to your baby or worries about accidentally hurting them, right? Um, Sometimes people have thoughts that don't make sense or don't reflect what they actually want to do. Have you had anything like that come up? This kind of opens up the opportunity for them to share because oftentimes they won't share this unless you ask because it's very disturbing. Unless you have that, really good connection with them, you've been meeting with them for a long time, but still, like I know even for me, I didn't know this was a thing whenever I was pregnant and postpartum until I went through the training through PSI. And so this is something that is not common knowledge often. So important note, intrusive thoughts, so dropping the baby dying are common in postpartum OCD and anxiety. They can often cause distress because they go against the person's values. And the intent to harm, again, may be associated with depression or psychosis or certain cases of bipolar disorder. And that's where you want to initiate further assessment and possible safety planning if that intent is there. Um, Follow-up statements, you can say things like, it's really common to have those thoughts when you're exhausted and overwhelmed. It doesn't mean you're a bad parent, right? I want to support you in understanding what's coming up emotionally and how to cope with it, not to judge or scare you. So again, we're validating them in that space. Um, Separating thought from intent, so helping them kind of distinguish. So having an upsetting thought is different from wanting to act on it. When you have those thoughts come up, how do you feel about them? Do they scare you? Are they distressing for you? Have you felt like you wanted to act on these thoughts, or are they more like unwanted images that bother you? So these are some things that we can say. We want to avoid asking, do you want to hurt your baby? That can shut down a conversation, right? Or create that fear of being reported to DCS or Child Protective Services. Making assumptions about safety based on the presence of intrusive thoughts. So again, that's why we want to ask further questions to gauge where they're at with that. And unless actual intent or plan is disclosed, you want to avoid urgency in response. So just because, right, like in this conversation, right, if there's no intent there, then we don't have a duty to report, right? Because there's not an intent there to harm. A lot of, again, this can sometimes be disturbing for therapists because they'll hear things, like I had this vision that I harmed my baby in this way, but it scared me, and I would never do that, right? Um, we're not going to call DCS in a situation like that because, again, there's no intent there. And I'll get to the psychosis piece, too. Um, Postpartum PTSD. So it's often after a traumatic birth or NICU stay, or again, like processing through a pregnancy experience. After a miscarriage, they're now pregnant. That might also be a time where you utilize, certain interventions based around like trauma-informed care. So this can include flashbacks, hypervigilance, nightmares about what they experienced with the birthing space. It can even be things that people say to them, right, in the birthing room, or something that they overheard a doctor say. Um, it doesn't necessarily have to be something that happened to their bodies during that process. It can just be really anything. And avoidance of reminders. So they avoid hospitals, OB visits, things like that. Postpartum psychosis. So again, this is rare, but it is like one to two in every 1,000 births. So this is where you'll see like those hallucinations, those delusions, where they're seeing things, or there's that like intent to harm themselves or others, rapid mood changes, maybe they're not sleeping at all. This is an emergency. So if you have, um, you know, I always, and I think one of you guys asked a little bit about like work with like the family or like the partner. So I am not a couples therapist. However, I do let the partner join one of the sessions before. Usually clients prefer it like third trimester, like at the end of second, to kind of, and we decide what we're going to focus on, but a lot of the times it's focusing on boundaries, what that looks like for them. I do go over all of this stuff with them, like what to look out for. Postpartum Support International has amazing resources that you can just print and hand to families. But I do inform the partner of like, if you notice any of these things, this is a medical emergency and you need to take them to the hospital immediately. So that is something that I educate them on is, again, what to look out for, because often when we're in that space, of just having had a baby, we are not, the birthing person, right, is not aware of, what they're going through or the depth of that, right? And a partner might see that more clearly for that person. So working with them on like, how can you best support them after, right? And during, and then how can you also support yourself, right? Because the partner needs to be taking care of themselves as well. So I do go through some of that, and I can answer more in depth about that towards the end. Postpartum bipolar disorder. So this is often misdiagnosed as depression. So you'll see like more manic episodes postpartum. They might require mood stabilizers. You might see that sleep piece, right? Where there's those manic episodes, they're not getting sleep. But it's like more extreme than just normal sleep deprivation. Um, this I encourage close collaboration with a psychiatrist on this. Um, Coordinating with a psychiatrist when you have perinatal clients on medications, I think is necessary in working with this population. You gain insight, you're able to coordinate care more effectively. It's really, really important because they often see things that we don't as therapists, or they can confirm things that maybe we suspect. Red flags for postpartum bipolar disorder, you're going to see that high energy, grandiosity, poor judgment. Maybe they're very impulsive. Um, yeah. Partner PMADs. So up to 1 in 10 partners can experience a PMAD. Depression and anxiety is the most common. And it's often under-identified because of the fear of stigma, again, lack of screening, cultural norms. Um, there's this like, you need to be strong for the mom, or you need to help them out, right? There's a lot of focus on the person that had the baby and not so much on the partner. So this is something I feel like that we're doing better at, talking about, but that support is still lacking. Symptoms can include irritability or anger, withdrawal or numbness. A really common one is increased substance use. You'll see that a lot. Workaholism, so kind of distracting themselves from reality of what's going on. And then you'll see that sadness, worry, and hopelessness. And oftentimes the partners don't identify with this, right? Because, they don't recognize that, like, I can have, a mood disorder or like anxiety or depression, right, as well. And at the end, I'll go over kind of some of the resources that we do have for partners or dads. Some support strategies, normalizing and validating the experience is one of the most important pieces. I think in working with this population, I have a book at the end that I will recommend to you guys. But really, the biggest thing in working with this population is giving them the space to be open, to be heard, to be validated, validating that experience that a lot of this is normal and so many people go through it, right? And that they're not alone in that. Just hearing that can be so helpful. Using a trauma-informed lens is often very helpful too. Those of you that are EMDR trained, I know a lot of you said you are, I am as well. I utilize EMDR a lot in my sessions. Even if it's preparing for birth, you can utilize EMDR to help them kind of prep for those fears around what that's going to be like for them. Um, Miscarriage too, kind of desensitizing that miscarriage experience. Can be extremely helpful. I've seen that with clients that I've had that have had a miscarriage, that EMDR can be really, really effective in helping them kind of let go of, that experience to allow themselves to, be more present in this current pregnancy. Um, Psychoeducation and self-compassion tools. So, right, like using psychoeducation with the clients, I use this so much with them, helping them learn because the reality is that medical providers often, right? Again, some of them do, but often are not educating people on like what their options are or even little things, right? Like when the baby's here, like what diaper rash to use or like little random things that you just don't even think about. Um, or what to do when they spike a fever, or whatever, right? Like there's a lot of different things. But psychoeducation can be really big, and especially when they're prepping for the birthing process, helping them learn like what that looks like in the environment that they're birthing in, because obviously it's different if they're going to be at an at-home birth or a hospital birth or a birthing center. It looks different. Um, I also really, really, really encourage the use of a doula. So I'm a big believer in like referring them, like if that works for them, right? It's not for everybody, but if they're open to that, I usually give resources on doulas that they can utilize. And a lot of my clients have found that to be extremely helpful because they do a lot of education and support, hands-on support, right? I talk a lot about how that doula support is extremely helpful for the partner as well. A partner has never often, right, when it's a first birth, has not gone through this before. And so we expect, the partner to just be there and support them in the way that they need. They don't always know, right? Or maybe they have anxiety around or fears around the hospital environment or what might happen. Seeing somebody that you love go through something so intense can be traumatic, right? And so having that third party to be there to like support both parties, give that birthing partner a break, um, those things can be so, so helpful. Um, Exploring identity shifts and grief. This is huge. I think there's always a grief piece to some extent in just becoming a parent, whether it's like involving the birth, whether it's involving like your baby growing up or, letting go of something you thought the way you thought it would look, right? Or letting go of the old me. Like it's no longer just me. Like I have this other little living thing that relies on me, right? So there's grief, work involved in all of it. And those identity shifts can be really, really massive for a lot of people. Assessing for safety and support systems, these are also very big. I always review with them like support systems. Who can you call on like in the middle of the night if you need something, or to bring you a meal, or to come, hold the baby so you can get a, 20-minute nap or whatever, right? So I help them define that and what that looks like before the baby's here, because that's often something that people forget to kind of think about or even have conversations with that support system. That's also extremely important. Like encouraging them to have that conversation of like, hey, can you be somebody that I call on? Effective modalities, so CBT, IPT, EMDR, ACT, psychodynamic and relational approaches. I won't get into these too much, kind of just to kind of throw these out there for you guys. Trauma-informed therapy, obviously, with an integrated approach. Group therapy and peer support is huge. I think the ability to be in a group setting and to hear from other moms that are going through the same thing as you can be extremely validating. So I always encourage them to get involved with like a postpartum support group. There's free ones out there, there's paid ones out there. And if you guys ever want like a list of those, I'm happy to like send you some that I usually recommend. Mindfulness-based interventions. Mindfulness is huge. I think I actually forgot to include this on here, but there's a book that I recommend. Um, it's like 5-minute mindful mantra or mama moments, we call them, where it's like little things, right, that they can hold on to like throughout the day, because oftentimes you don't get a break for yourself, right? Depending on the age of your child. And so if it's the one that I use so often is like if you're a coffee drinker or like a tea drinker in the mornings, right? Like doing that, the five senses kind of thing with that, where you're taking that coffee and you're like feeling what it feels like in your hands. You're taking in the smell as it brews or before you take that first sip. You're really savoring that taste on your tongue, right? Um, so really, or like, watching the steam come off of the top of the mug or whatever. Those little things, or showers, like teaching them like in the shower, like really pay mind to what it feels like on your back. What does that heat feel like? What feelings does it bring to you? What does the smell, do for you? So teaching them little things that they can do like that throughout the day can be really effective to them getting that mindfulness piece and not feeling like they have to like put the baby down and go do it, right? Like they can do it as they're holding baby or whatever. Screening tools. So the Edinburgh postnatal depression scale utilize this a lot. Um, the PHQ-9, the GAD-7, which all of you might be familiar with. The mood disorder questionnaire, we use this when bipolar disorder is a question. And then asking about intrusive thought safety, which you kind of went over, and then being sure to check in regularly. We actually, and don't quote me, but we encourage screening, like oftentimes, right? They'll do it like 6 weeks and then a year. It's becoming more common to do it more often, but PSI actually recommends doing it like 6 weeks, uh, 3 months, 6 months, and don't quote me, but it's way more common. And they encourage this to catch, because again, these can pop up anytime in the first year. So we want to make sure that we're catching that. Some resources for you guys. So postpartum.net, that's a PSI website. They have a PSI provider directory if you ever want to refer out to somebody that's a perinatal mental health certified therapist, or even like a psychiatrist, right? Because there's psychiatrists that are also PMHCs. I usually refer my perinatal patients out to people that are PMHCs just because they have this understanding of the different things that pop up. Um, PSI trainings and the PMHC certification, if you're interested in that. The certification, if you guys aren't familiar with it, it's a 2-day training, and then you have to do an exam, and then you have to have like ongoing hours every 3 years. So that's kind of how the certification is. It's somewhat of, and it can be costly to some extent. However, they do offer scholarships. So I really encourage, if you're interested in this, to apply to those. They're hoping to give out a lot of them this year because they want more certified clinicians. Um, PSI webinars and support groups for clinicians. That's another resource. The PSI website, you can get on there and look. They have handouts. They have book recommendations for both therapists, professionals, and clients. Um, they're just an amazing resource. I tell all of my clients about them as well. They have free, which I'll get into this, but free support groups as well, that are online. And they also have like a postpartum planning workbook for clients that I will always print out. And I usually give it to them in like that couple session if they want to do that, or I'll give it to the individual for them to like do at home with their significant other. Books and training. So this information for therapists. So the art of holding in therapy. This is really a really good one. It talks about like the art of holding that space for postpartum depression and anxiety. This is a really good one. Karen Kleiman is amazing in this field. This isn't what I expected by Karen Kleiman and Wenzel. Good Moms Have Scary Thoughts. I tell all of my clients about this book as well. This talks about like that intrusive thoughts piece and kind of validates some of that for them. So that's a really great book to refer them to. Again, the PSI 2-day certificate training, the PMHC credential, and then local groups that meet. Some client resources. So they have a 24-hour warm line. This is the line that they can text or call if they ever need to talk to somebody. And they can kind of help them out with anything that they need, or get them connected to like a local resource or therapist or psychiatrist, whatever they need. That is a PMHC. Again, free virtual support groups on PSI. They're all listed on there. They also have support groups for partners. So that's another big one on there. The Canopy app, this is like an emotional wellness app. They have a lot of different things that you can check out. And then again, the local perinatal therapists and support groups. Um, so let me see the questions that you guys had. So again, including partners and family. Yes, I really encourage that. I also have a lot of clients that go to marriage therapy on the side, which can be a really big one, especially for the first 3 months of the first baby are so hard for people. And so oftentimes they just need a little extra support. And so that can be really, really helpful. Let me see. Yes, the OCD and ADHD increase in symptoms during pregnancy and postpartum. Again, right? Like you've got the hormones at play. You have the identity shifts. You have the fears of the unknown. You have all of these things that kind of peak. And the OCD piece, right? Like those intrusive thoughts, the impulsions and things like that. That is very, very common. So that is something, again, that to pay mind to as you're working with these clients, because it is pretty common to see that peak. Let's see. Can't understand some of my writing. Biggest challenges, sleep. What things are helpful? So, right, like a lot of it is outside of our control, right? But some of the things, like I kind of help them decide, like, well, I kind of help them discover what is within your control, right? You can have your partner take over some of the feedings in the middle of the night so that you can sleep, right? You can, take turns taking naps in the middle of the day, right? Like you're in charge of watching the baby or whatever. Um, Again, support system, having that support system, somebody that can come over and help so that you can get extra sleep. Um, those are really like, although those are very small, right? Like those are the little steps I would say that they can take to do that. And then just making sure that they're replenishing, their bodies after birth. Eating healthy, like diet and exercise and those types of things are, exercise after, right? They're cleared. But those things are so, so important. One of the things that I encourage too is getting outside. Babies are up early, right? Naturally. Getting outside for that first hour of sunlight. Oftentimes with postpartum depression, you'll see a dip or like a lack of vitamin D3 levels. And so I always, if I have a client that is struggling, I always encourage them to go get blood work if they haven't and ask them to get like a vitamin D3 level. And a lot of times it's low. So then they know to supplement. And so the doctor can guide them on that. But that is a really big one too, is the vitamin D3 levels with postpartum depression, postpartum anxiety. Sunlight alone is not often going to give you what you need, and so they often have to supplement with that. But that's something to know too. Um, so those things can kind of help pick up your mood, right? Give you some energy, making sure that they're eating like, mo mini meals throughout the day, right? They're not just like eating breakfast and then waiting till late afternoon to eat again, but they have people that are either like making food for them, supporting them. Oh, it's already 1 o'clock. Um,
You're just a wealth
but
of
yeah,
wisdom. Yeah, these are all great things to be mindful of.
yeah,
So appreciate you, Erin. How can people get connected to you if they want to like staff a case with you or send clients your way? What's the best way to get in touch?
yeah. So my email is Erin Regan at therapysecure.com. I am on Instagram, but I'm not as bold as Ellie. I'm pretty sure I have one post and it's been like a year since put it on there. But you're welcome to follow me on there. I don't post often. It's one of those things that maybe down the road I'll take over, but I am on Instagram. But yeah, emailing me is probably the easiest. Um, and yeah,
Yeah,
anything
awesome.
else?
That's great. Thank you so much for sharing. And
Yeah,
yeah, just really appreciate your friendship in this and also your expertise and sharing that with all of us here.
yeah.
Right. Well, I'll let folks get off to whatever they're headed off to, but have a great rest of your Tuesday.
Thanks,
All
Erin.
right, thank
Thanks,
you.
Ellie.
All right. Bye.